The subject of Chapter 19 is immune system disorders, and while there is a ton of really interesting and important information in Chapter 19, the amount of information that's there is really just too big to talk about in a microbiology classroom. And in addition to that, a lot of it has to do with things that really belong more in a pathophysiology discussion. So what I thought we would do with Chapter 19 is, rather than looking at the chapter as a whole, we would instead take a few minutes to concentrate on immune system disorders that have some relevance in a microbiology classroom. So immune deficiencies generally can be divided up into two groups: congenital immune deficiencies, which are genetic in nature. So you have a person who inherits a defective gene, and we actually did talk about this back in Chapter 9. We talked about the treatment of severe combined immunodeficiency syndrome by the insertion using a viral vector of a normal gene into a person whose body only produces the defective gene. And when you do that to the person's bone marrow, you can cure the person of severe combined immunodeficiency syndrome. So because a virus vector is used there, then there is some overlap between genetic diseases and microbiology, but we're not going to focus any more attention there. We're just simply going to remind ourselves of the fact that that was the case back in Chapter 9. And instead, we're going to focus on acquired immune deficiencies. And in particular, we're going to be focusing on acquired immune deficiencies that happen naturally as a result of infection with a microbe or microorganism. So we're not going to talk about the facts that drugs can either intentionally or inadvertently suppress the immune system. We're not going to talk about cancers of the immune system. Instead, we're going to talk about acquired immune deficiency syndromes as they relate to infectious disease. One nice thing that this chapter will allow us to do, because we're going to look at an acquired immune deficiency syndrome, it allows us to take that microorganism as an etiologic agent of disease, look at the epidemiology of that etiologic agent, and thereby revisit some of the topics from Chapter 14. It allows us to talk about the pathology of the microorganism, which allows us to go back and talk about topics from Chapter 15. Because it is a disease of the immune system, we can see how this disease affects the innate and the adaptable defenses of the body, and that way we get to go back and look at Chapter 16 and 17. We get to look at some of the techniques we discussed in Chapter 18 in terms of how to diagnose and track this illness, and then finally we wrap it all up and give ourselves a really nice, I think, synopsis of this unit prior to taking your lecture exam. So without further ado, acquired immune deficiency syndrome, which was first reported in the United States in a Centers for Disease Control Morbidity and Mortality Weekly report published. And a piece of that MMWR is shown here for you, and it says, in the period October 1980 to May 1981, 5 young men, all active homosexuals, were treated for biopsy-confirmed pneumocystis carinii pneumonia at 3 different hospitals in Los Angeles, California. 2 of the patients died. All 5 patients had laboratory-confirmed previous or current cytomegalovirus infection and candidal mucosal infection, and then a case report of each of those patients followed. So a couple of things to notice right off the bat that may not hit us like they would hit a public health official. So I'm going to help you out a little bit with this one. So what we're looking at are things that would be out of the ordinary. So first of all, 5 young men, young adults, should have healthy immune systems, should be healthy. The fact that they are ill raises some red flags. The fact that they are active homosexuals tells us there may be a lifestyle or perhaps a community connection between what's going on with them. The fact that they were treated for biopsy-confirmed pneumocystis carinii pneumonia raises serious red flags for public health officials, because prior to 1980, the only population with a significant number of pneumocystis carinii pneumonia cases were pediatric oncology wards. So kids that had undergone chemotherapy in order to knock out cancer then became susceptible to this pneumocystis carinii pneumonia. So pneumocystis carinii pneumonia is an indicator of immune system failure. The fact that these 5 young men were treated at 3 different hospitals is relevant, because it tells us it's very unlikely that there is a hospital-acquired aspect to this illness. The fact that 2 of them died tells us this is a very serious illness. And the fact that all 5 also had confirmed previous or current cytomegalovirus and candidal mucosal infections tells us 2 more big things about their immune system, and that is that their immune systems are not functioning. You and I would probably have IgG to cytomegalovirus and never have known that we ever had cytomegalovirus infection, because it's unheard of for a person to have active infection. And again, same thing is true with candidal mucosal infections. So this would be a yeast infection of the mouth or other mucous membrane, which is incredibly uncommon. The only place you really find that would be in babies who are breastfeeding. So we have 5 young men who have something in common, who are all showing signs of immune system failure. So in 1981, we have the publishing of this MMWR, which highlights pneumocystis carinii pneumonia. And what they also found within primarily the male homosexual community was, in addition to pneumocystis carinii pneumonia, which is abbreviated PCP, or cytomegalovirus infection, which you see there abbreviated CMV, a kind of cancer called Kaposi's sarcoma. And again, this cancer is not seen in people that have functional immune systems. About 2 years later, HIV was discovered in 1983, and you can see a scanning electron micrograph here of the HIV particles attached to a CD4 positive T cell, which is a helper T cell. And by the time this etiologic agent of AIDS, acquired immune deficiency syndrome, is identified, there is a pandemic. There are 200,000 people thought to have been infected already in 1981, and AIDS, the disease AIDS, not just the virus, but the disease AIDS, is found in 28 nations. So 2 years after its discovery, it's a deadly pandemic. So that leads us, once we have the etiologic agent, to be able to go back and do a retrospective analysis, collect some data, try to figure out what's the epidemiology of this disease. Because at this point, we don't know how it's transmitted. We have some idea, but it's not clear. And so epidemiologists go back and try to reconnect the lines and discover how this disease came to be, because it did not always exist in the human population. They're able, because they've learned enough about this virus, to identify pieces of the virus that they can go looking for. So one big target that can be identified and used to determine whether or not the HIV particle is inside of a host body is this glycoprotein 120, which is present on the surface of the HIV particle and is used for attachment of the virus to a host. This virus is a retrovirus, so it contains a reverse transcriptase enzyme. Retrovirus, you might remember from chapter 13, means that this is an RNA virus, which reverse transcribes its RNA genome into DNA, integrates that DNA into the host cell chromosome, and then carries out the rest of its reproductive cycle. So this virus with these proteins means now we can identify and try to find this virus. And as they backtracked it, they actually thought that a simian immunodeficiency virus of chimpanzees crossed the species barrier to human beings, probably in a manner very similar to Ebola or COVID-19 coronaviruses, where there's an animal reservoir, and because people are butchering and eating those animals, that pathogen which is present in the body of the animal host can be transmitted to the human host. So 1930 crosses the species barrier. In 1959, we have what is thought to be the first death of a person in the Congo due to acquired immune deficiency syndrome. By 1968, HIV is present, we think, in the United States, again, based on autopsy reports and some preserved tissue samples. And it looks like the route that HIV took was not directly from Africa to the United States, but it went from Africa to Haiti into the United States. And as of 2017, obviously fast forwarding quite a bit there, 36.9 million people have been infected with HIV and AIDS, and about 1.8 of them are less than 15 years old. That's current. Total, there have been 77.3 million HIV infections, and 35.4 million people have died of AIDS since it crossed the species barrier in 1930. And one of the most scary statistics about acquired immune deficiency syndrome is that because it's considered a persistent infection and it has what seems from the outside to be a latent period, you actually do have viruses, but you don't show any symptoms. 25% of HIV positive individuals don't know they have HIV, which means they're not being treated for HIV, and that means that they don't know that they could be giving HIV to someone else. Some good news, about 1.6 million infections among children have been averted by the use of anti-HIV antiviral drugs. Although in 2016, 24% of HIV positive mothers worldwide lacked treatment, which meant that 160,000 babies were infected transplacentally with the HIV particle. So that's as of 2017. So right now, currently, as of 2017, by the way, you may be wondering why 2017 when it's 2020. It just takes a long time to compile these data. So these are the latest data that we have that have been statistically analyzed to make sure that they're accurate. So as of 2017, about 37 million people living with HIV and AIDS, 1.8 of them under 15. In 2017, there were 1.8 million new infections, and about 180,000 of those were in children less than 15 years of age. And in 2017, 940,000 people died, 140,000 of which were less than 15 years old, which is a devastating statistic, but the good news is that number has decreased 51% since 2010. And one of the reasons that those numbers are getting better is because access to treatment is increasing all the time worldwide. So kind of in a nutshell, HIV/AIDS in 2017, 75% of people are aware of their HIV status, of which 79% of them are on HIV treatment, and of them, 81% are virally suppressed. So 75% of people who have HIV know it. Of them, 79% are getting treated, and of them, 81% are virally suppressed, or you'll oftentimes hear are in remission from AIDS. So this is fantastic information, because though we don't hear a lot about HIV and AIDS, I think in the United States, worldwide, as you'll see as we move through these slides, it's a huge, huge problem, right? And never forget, right now, right, 36.9 million people living with HIV and AIDS. So probably a dumb question, but how do you contract HIV? Like any other infectious disease, you have to have transmission, and in the case of HIV, transmission is direct contact transmission with infected body fluid. So this is considered a sexually transmitted infection. The major mode of infection is through sexual contact because this virus has a high load in semen, in vaginal secretions, and because it's found in helper T cells, it's also found in the bloodstream. So sexual contact is the major mechanism of transmission, and the risk associated with sexual contact has to do with the kind of sexual contact that is engaged in. So the most at-risk group are men who have sex with men, followed by men who have sex with women, and then women who have sex with women, and then artificial insemination. And I bolded and put some asterisks there next to women who have sex with women because until just recently it was thought that women could not contract AIDS from sexual contact with another woman, but that actually has been disproven in a recent study. So sexual contact's the big one. Blood contaminated needles, of course, because the virus is found in the blood, organ transplants or blood transfusion will also transmit the virus. Breast milk can actually transmit the virus, and the virus can cross the placenta and infect the fetus, and that accounts for about 90% of children ages 0 to 4. So when we talk about pregnant mothers who are not able to access care, what we're saying is they don't have the drugs to decrease their viral load to the point that the virus cannot move across the placenta. So though it's important to treat the mother, it's that you're preventing infection of the baby. Now, the interesting thing about HIV transmission is that in developed countries and developing countries, the modes of transmission, though they are the same, the likelihood of infection is very different. In developed countries, men who have sex with men account for almost half of all HIV cases, followed in those who know what their risk is by intravenous drug use. And you'll notice heterosexual contact accounts for very little of the new HIV cases, whereas in developing countries, heterosexual contact accounts for over 1/3. So what you see in developed countries is men who engage in what's called receptive anal sex, contracting HIV at a very high rate. And in developing countries, it's women who engage in receptive vaginal sex, being at risk most greatly for HIV contraction. So the major take-home message is the body fluid that contains HIV at its highest levels is semen. So anyone who engages in receptive sex and is exposed to semen is at higher risk for contracting HIV. The reason that transmission tends to be higher in individuals who engage in receptive anal sex is because the epithelium of the gastrointestinal tract is much thinner and more likely to tear than the epithelium of the vaginal canal. And so it's much more likely that the virus can get through a break in that skin because it's actually most commonly a parenteral infection where there's a small tear in the mucous membrane and that allows the virus access. Some data that support that are shown here. So receptive anal sex, there have been 4 studies done, and the incidence of contracting HIV through receptive anal sex with an HIV positive insertive partner is 1 in 71. Insertive anal sex, so the person who is releasing the semen, it's 1 in 909 in circumcised individuals and 1 in 161 in uncircumcised individuals. There have been 10 studies looking at what happens with receptive vaginal sex, and the risk is about 1 in 1,200. Insertive vaginal sex, the risk is about 1 in 2,500. So receptive vaginal sex would be the female partner in a heterosexual sex act. The insertive vaginal sex would refer to the male partner in that act. So overall, receptive anal sex has a risk of about 18 times receptive vaginal sex, and receptive anal sex has a risk of about 23 times that of insertive anal sex, and receptive vaginal sex has about 2 times the risk of insertive vaginal sex. Additional risks include sex with a person who has acute HIV infection. That increases your risk by 26 times because that person's viral load is so high. And then a similar additional risk would be if the viral load is higher, the increased risk is also present. One other really interesting point of research has to do with one of the protozoans that we discussed in the diversity unit, schistosoma. Because schistosoma are found in the water, they actually can swim into the vagina and burrow through the vaginal wall, creating a sore, which then allows HIV to have a straight shot into the vaginal canal. And it's thought that that might be a huge indicator for why heterosexual contact in the developing world is so much higher for women than it is in the developed world, because schistosoma is endemic in much of the developing world. So this is a direct contact transmission disease which seeks to find a target cell. Its primary target cell are helper T cells. It can also bind to a couple of different body cells. It can bind to the intestinal epithelium, it can bind to brain cells, and it can bind to antigen presenting cells, which also have a CD4 positive receptor. The reason we don't say that these are really target cells is because if the virus gets into any of these cells besides the helper T cell, that becomes a dead end for the virus. The virus can't replicate inside of those cells. So this is not something that you can contract from water or food, right? It's not a vehicle transmitted disease, because if it happened to bind to the intestinal epithelium, it wouldn't be able to reproduce in the intestinal epithelium. Now, what knowing that these targets are available explains for us is some of the symptoms and signs of HIV infection and AIDS, because people who have AIDS oftentimes have AIDS-associated dementia, they have chronic wasting, nausea, vomiting, and you can imagine if the intestinal epithelium is infected, even if it's a dead-end infection, or if the brain cell is infected, even if it's a dead-end infection, if those cells are not operating the way that they're supposed to be, then the body does not behave the way it's supposed to be. Also, the fact that these antigen-presenting cells, which are parts of the innate defenses, can be infected means that they won't be working as well. So target cell primarily the helper T cell, and replication of the HIV happening within the helper T cell. So replication occurs just like any other virus. We have attachment, penetration, biosynthesis, maturation, and release, but this virus can undergo a latent cycle. So not that it's a latent disease, because you will always have virus and you will always be infective, but it has a latent infective cycle and an active infection cycle, like the herpes virus that we talked about in chapter 13. So HIV binds to the CD4 receptor of helper T cells. That's attachment. It penetrates, it releases its genome, it reverse transcribes its genome into DNA, which it then inserts into the chromosome, which you can see there. And it can simply persist in that helper T cell as just a provirus. Now, what will happen ultimately is that that provirus will become activated, and it will undergo biosynthesis, maturation, and release of the progeny HIV into the body. And what that means is if you want to look for HIV in a patient, you have to be able to look for viral DNA, because that tells you whether the infection is latent, and you have to be able to look for viral RNA, which will tell you that the infection is active, right? Because DNA tells you it's hiding inside cells, and RNA tells you that there are viruses floating around inside the body. So you can look for HIV directly in order to look for both of these things, or you can look for HIV indirectly. But HIV diagnosis is typically done looking indirectly because the virus is at such a low load, there's a risk that you will have a false negative. So screening tests for HIV are done looking for antibodies to HIV 1 and 2. So of course those would look very similar to this diagram we have set up here, where you have antigen, right? HIV 1 and 2 antigen adhered to the surface of a microtiter well. You would add the patient sample. If the patient sample contains HIV antibodies, they will bind to the antigen, and then you will add that secondary antibody which recognizes the patient antibody and causes that positive reaction on the left, and the lack of that reaction on the right gives you a negative test. Positive on the left is still invisible at this point, but remember the enzymes that are linked to that antibody in an enzyme-linked immunosorbent assay will convert colorless substrate into a colored product and give you a visible result. So HIV is diagnosed typically through ELISA, and initially it's done indirectly by looking for antibodies to HIV, because whether or not you can find the HIV, you will see the memory that a person has to this infection. So this is typically done looking for IgG, because of course memory to HIV means that you are infected with HIV, because this is a chronic, not a clearable or acute disease. What you can also do is look for some of the viral proteins using ELISA. And so those are diagnostic methods. What can kind of explain for you where a person is in this HIV infection process can be done looking for the number of hidden viruses inside helper T cells, and also looking for the number of viruses floating around in the body. And the reason we can differentiate between those two is because, as we mentioned in the previous slide, the provirus, the one hiding inside the helper T cell, will exist as DNA, whereas the virus floating around all by itself will exist with an RNA genome. So you can do a PCR looking for viral DNA, and that will tell you how many proviruses there are, how much latent infection is happening, and you can do a reverse transcriptase PCR looking for viral RNA, and that viral RNA will give you an idea of the viral load of the patient. And those are two really important qualifiers when you are treating HIV, because looking at how much free virus there is will tell you how effective your current treatment regimen is. And thankfully, there are multiple different treatment regimens that can be used in order to combat HIV. They're all grouped together as HAART treatments, which stands for highly active antiretroviral therapy, and they've been around since 1987, which is pretty extraordinary if you think about it, because they identified the virus in 1983, and by 1987 they had come up with a growth factor analog for thymine, a nucleoside analog of thymine called azidothymine, which is able to confuse the reverse transcriptase enzyme and is selectively toxic because you don't have a reverse transcriptase need, you don't have a reverse transcriptase enzyme, and you don't ever take your RNA and convert it to DNA. So in 1987, Retrovir was a trade name for the first AIDS therapy, and it was a nucleoside analog which blocked reverse transcription. So the virus could attach, it could penetrate, but it could not incorporate its viral RNA into the genome of the host cell. And if it couldn't integrate, it couldn't transcribe and translate those proteins, it couldn't make baby viruses, and the procedure halts. So today we have a lot of synergistic combination therapies. So not just one drug, but multiple drugs used in different combinations. And Some of them target reverse transcription, just like the first drug, azithromycin. Some of them block the virus from fusing, so they block attachment and penetration. Some of them block the integration of the newly reverse transcribed DNA into the host cell chromosome, and some of them block the ability of the proteins to convert the inactive virus into its active virion form that you might remember from chapter 13. So remember in chapter 13 we talked about the fact that viruses can be described as viruses or virions. Virus doesn't necessarily mean metabolically active, whereas virion does. So HAART, highly active antiretroviral therapy, began in 1987, and today one of the best things that we can report about HIV and AIDS is that the number of people receiving treatment, this HAART treatment, has increased over the last 17 years wildly. So in the year 2000, there were 28.9 million people living with HIV, and only 770,000 of them were receiving treatment. And so the total number of people includes the orange and the blue icons, but look over time, look from 2000 to 2005 to 10, 13, 14, 15, 16, 17. Look at how much more of that total number of people is shown in green rather than orange. And in 2017, 21.7 of 36.9 million people living with HIV were receiving treatment. So this is excellent news. This is cause for celebration, but it's not reason to stop fighting, because there are still millions of people who do not have access to antiretroviral therapy. Now, in the United States and other developed countries, not only is this antiretroviral therapy available for people who have HIV, it's actually been used as a preventative or prophylactic treatment. So currently in the United States, there is pre-exposure prophylaxis, or PrEP, which comes in the form of a pill called Truvada, for instance, which is a 1 pill per day reverse transcriptase cocktail. And if you take this pill, it will give you enough of a level of this reverse transcriptase inhibitor in order to block the majority of viruses from getting into the body. So in order to provide protection, if you are compliant 4 times a week and you engage in receptive anal sex, you will have protection against HIV. In order to gain that same level of protection for receptive vaginal sex, you have to be nearly 100% compliant. And the reason for this seems to be that the level of the drug in the intestinal epithelium is much higher than the level of the drug in the vaginal epithelium. So if the virus takes the route of the vaginal epithelium, it's less likely to encounter the drugs than if it moves through the gastrointestinal tract through a tear. So you can see here the efficacy of PrEP for men who have sex with men is almost 100%. In women who have sex with men, it's about 70%. In intravenous drug users, it's only about 50%. And the reason for that is that this drug is cleared very quickly from the bloodstream. So if you inject the virus right into your bloodstream, it's much more likely to find a host cell before it can be wiped out by this drug. It's much more likely to get into that helper T cell, undergo the replicative cycle, and get itself at least hidden inside the host cell chromosome. So this isn't really helpful for intravenous drug users, though it has the ability to drastically decrease the risk of unprotected sex, primarily, as I mentioned, in men who have sex with men, and then followed by that, men who have sex with women, women who have sex with men, and then intravenous drug users. And the differences there, right, again, remember, have to do with whether or not you're having receptive anal sex receptive vaginal sex, or you are the insertive partner in either of these. Now, the problem with pre-exposure prophylaxis is that it's not perfect. It's not without its risks. Even antibiotics have their own risks. It can exacerbate hepatitis B virus infection. If you have an undiagnosed HIV infection, you will create resistance to these drugs in your body. And so if you take PrEP, you have to have an HIV test done every 3 months. It can cause kidney injury, so kidney tests and liver tests are done every 3 months while you're on these therapies. It causes osteoporosis, and of course, and this is a big one, there is absolutely no protection against any other sexually transmitted infection if you are taking PrEP. So though this is available, by far the best option is using a prophylactic called a condom. Okay, so let's assume you've been exposed through direct contact transmission. You have contracted the virus. What does HIV and AIDS look like in its host? So the stages of HIV infection include 3 phases. Phase 1, where the person is either asymptomatic or might have chronic lymphadenopathy, which is chronically swollen lymph nodes. Phase 2 is where a patient becomes symptomatic and they have indications of some level of immune system failure, and then phase 3, which is clinical AIDS. So phases 1 and 2 are HIV positive, phase 3 is AIDS. And the way that you gauge whether or not a patient is in these phases has to do with signs and symptoms, but also with the level of CD4 positive T cells in the body and the level of HIV in the body. So the CD4 T cell will tell you how healthy the T cell population is and how many of them are latently infected with HIV. HIV in the bloodstream will simply tell you the level of immune system failure, because as the immune system fails, the immune system is incapable of pulling those viruses out of the bloodstream. So when a person contracts HIV, their helper T cell count, which is normally 1,200 cells per microliter, plummets to about half that because the HIV infect them and undergo acute infection. So virus comes in, attacks these helper T cells die, release tons of viruses, and notice right after infection, about 2 months after infection, the population of HIV in the bloodstream is higher than it will ever be. It's about 10 million viruses per milliliter of blood. Really, 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 really high as compared to what it will ever be again. Now, this is oftentimes not noticed clinically because people don't go to the doctor. Usually, if people have symptoms of this immune system switch, they feel like they had a severe flu or something like that. So they don't feel well, but because their immune system is functioning normally, they notice quickly clear almost all of the viruses out of the bloodstream and their T cell population recovers. Notice though that the population of helper T cells does not go back up to the normal level of 1,200. So you're already immunocompromised, and that's why you could have this chronic lymphadenopathy. You have chronically swollen lymph nodes because your immune system has become activated. So about 2 months following infection, the population of HIV in the blood peaks at about 10 million per mil. The population of CD4 positive helper T cells plunges and then recovers, but it does not recover to the point of normal. At this point, you would be considered seroconverted. You would have detectable antibodies against HIV in your bloodstream. You would have both IgM because you're fighting HIV, and you would start to have memory at about 2 weeks after that initial infection. So within about 3 months, and that number is getting shorter all the time, it used to be 6 months, within about 3 months, you will have detectable levels of antibody that can be used to diagnose HIV infection. So once that acute phase is all over, the HIV will stabilize at about 1,000 to 10,000 viruses per milliliter of blood, which is a really low viral level. To be honest, if you talked about something like hepatitis C infection, you would be looking at a virus that stabilizes at about 2 to 3 million viruses per milliliter of blood. So the viral load is fairly low, which is good news. And it remains steady through phase 1, through phase 2, but what doesn't remain steady through phase 1 and 2 is the helper T cell population. Notice that once the cells recover from that initial dip at the beginning of the infection, they just steadily decline, and as the T cells decline, because those are the helpers, right? They're the coordinators of both the humoral branch of the immune system, the cell-mediated branch of the immune system. They fire up all of the innate portions of the immune system, and because they are not doing their job, the immune system is not doing its job, and the person starts to show more and more signs of immune system failure, like Kaposi sarcoma, cytomegalovirus infection, pneumocystis carinii, pneumonia, candidal mucosal infections, all of these things that should not happen in a person who has a functional immune system. And then finally, after a period of years, the level of CD4 positive T cells drops below 200 cells per microliter, and you have moved from phase 2 into phase 3, which is AIDS. And because at that point the immune system has been so damaged, you will see a rise in the number of HIV in the bloodstream because there's really no functional immune system around to clean them up anymore. So the goal of treatment is not so much focused on the HIV in the blood, it's based on tracking that CD4 positive helper T cell population, trying to figure out how healthy the T cells are. And so tracking that over time and making adjustments to the heart treatment if the T cell population starts to decline, and if the T cell population starts to stabilize, maintaining that current treatment level. So the key with treating HIV is tracking the helper T cells, which can be difficult because T cells look like every other lymphocyte in the blood cell, right, or in the bloodstream. So here is a blood smear of blood, and try to figure out where the helper T cell is. It's here, which would have been very difficult to differentiate, especially from the white blood cell that is sitting right above him. So we can use some of those techniques from chapter 18 to identify our helper T cell. We can use a fluorescently labeled antibody, which will bind only to the helper T cell, much like the fluorescent antibody bound to the Streptococcus pyogenes in our chapter 18 example of a direct fluorescent antibody test. So you can fluorescently label white blood and you'll get something like this. And the problem there is that it's very easy to see yellow and orange and pink and green, but it's kind of difficult to count them. And in fact, some of them look ambiguous. So you can take these fluorescently labeled cells and you can run them through a fluorescence activated cell sorter, which you can see here allows those cells to move through in a single file line, and it shines a laser through them, and every time it finds a helper T cell, which has been labeled orange, it counts that. And in a healthy individual, about 56% of all of the cells that move through the fluorescence activated cell sorter will be helper T cells. So that would be an indicator of a person who is responding well to heart therapy. But if you look at the bottom there, the AIDS patient has a relative concentration of only 2.7% helper T cells. So that's how you could track the number of viruses in the body over time and adjust the treatment regimen. Because it's not so much about adding one, a tick mark to the column. It's about adjusting therapy in response to how well the therapy is working in the individual patient. So now that we kind of have a handle on what HIV infection looks like, let's take a few minutes to talk about some of the current data about HIV and AIDS. So worldwide, the infection trend of HIV is decreasing. 1.8 million people were newly infected in 2017 globally. That's actually a decrease of 18% a year since 2010. So in Western and Central Europe and North America, we have an overall decrease of 8%. In the Caribbean, we have an overall decrease of 18%. Latin America, a decrease of 1%. East and Southern Africa, a 30% decrease. Western and Central Africa, an 8% decrease. Decrease in Asia and the Pacific. And two outliers to that information, Eastern Europe and Central Asia had a 29% increase over this period of time, and the Middle East and North Africa had an increase over this period of time. So overall, the number of new infections is decreasing almost 20% every year, which is great. And when we look at these data for Eastern Europe and Central Asia and the Middle East and North Africa, we want to just make sure that we understand what those numbers are saying. Yes, there's been an increase, but if you look at the numbers, those numbers account for very few overall infections. So Eastern and Southern Africa and Western and Central Africa, which would together be grouped as Sub-Saharan Africa, has about 27 million of the 30 or so million HIV infections overall. So the fact that they are decreasing there is really, really good news. And that doesn't mean that we shouldn't be concerned with the Middle East and North Africa or Eastern Europe and Central Asia, but just to put that statistic in context, that doesn't mean that we're having an explosion of cases. It just means that in these areas, there have been more cases. So overall, HIV and AIDS is a disease of Sub-Saharan Africa, and it is a disease of young adults. 37% of new HIV infections occur in people age 15 to 24 years old. And worldwide, though in the developed world, it's a disease of men who have sex with men, 22% of these new infections are women aged 15 to 24. So geographically, it's a disease of Sub-Saharan Africa. Demographically, it's a disease of young people worldwide. And in the United States, those statistics are also true. So in the US, 1.7 million people have been infected and about 700,000 have died. 1.1 million adults have HIV and AIDS in the United States today, and 1 in 7 are unaware, which is an extraordinary statistic because just a few years ago it was 1 in 4 that were unaware that they had HIV, which meant they weren't getting treated and they weren't protecting other people from infection. About 6,500 people died in 2015 of AIDS as compared to 13,000 in 2013. There were about 38,000 new HIV infections in the United States in 2015, which is an 8% decline. As I mentioned, the percentage of people who are unaware of their infection has gone down significantly in the last decade. So these are all hopeful statistics that tell us that the work that we're doing to combat HIV and AIDS, not only throughout the world, but in the United States, are working, they're helpful. But one really big at-risk group, especially in the United States, is what are considered, I don't know if you could say young adults, 13 to 24-year-olds, because 51% of them don't know they're infected. And by nature of their age, they tend to be more risk-taking in their behavior, so they're less likely to be safe, to use prophylactics. And if they don't know they're infected, they are not going to be getting treatment. And we had a bit of a bump. Notice new infections in 2015, 38,500 in 2016, 39, almost 40,000 people were diagnosed with HIV in 2016. By far, the biggest group of people who are HIV positive in the United States are ages 20 to 29. And of those people, the biggest infection risk group are Blacks who have male-to-male sexual contact, followed by Hispanics or Latinos who engage in male-to-male sexual contact, and whites or Caucasians who engage in male-to-male sexual contact. So overall, in the United States, as is the case with all developed nations, this is a disease that primarily men who have sex with men are at risk for, followed by Black women who engage in heterosexual contact, Black men who engage in heterosexual contact, and then whites and Hispanic women who engage in heterosexual contact. So overall, Blacks account for almost half of all HIV and AIDS infections in the United States, although they account for only 13% of the total population. So it's not clear why that's the case, whether there's some sort of genetic predisposition or some other factor. The statistic simply says that Blacks are disproportionately infected by HIV, and that probably has a lot to do with this next statistic, and that is that HIV infection in the Southeast is much higher than other areas of the country. And I said that that probably is connected to this because if you look at population demographics, the population in the Southeast has a much higher percentage of Black Americans than other areas of the country. So you'll notice the darker the color, the higher the infection of HIV per 100,000 people. So this is a relativized statistic. Obviously, there are going to be more people in New York that have HIV than in Georgia, but in New York, the rates of HIV diagnosis per 100,000 people are 17, whereas in Georgia, it's 31. So that's taken into account the population levels of each of these. So lots of cause for celebration, I think, in terms of HIV research and HIV treatment and control, but certainly not a place to become complacent. This lecture is one small part of trying to not become complacent about something just because it's not directly in our faces.